Friends, complications do happen when we expect them the least. This is an interesting video which shows how a simple looking case planned for Toric Panoptix trifocal IOL developed posterior capsular rent and turned out to be a big challenge to me. Though posterior capsular rent is a common complication, but when you're planning for Toric Panoptix IOL, it becomes a very big challenge because we don't have to manage only PCR, but we also have to implant promised intraocular lens to the patient. But if we hold our nerves and keep patience, then it is still possible to continue with our primary plan. So friends, as you can see, everything is going very smoothly. After doing toric marking, capsulotomy has been done perfectly, hydrodissection is done, nucleus has been rotated, and everything looks going very smoothly. But now you just observe there is going to be a complication at this moment. And yes, you can see this posterior capsular rent infranasally. But where did I go wrong? Everything seems to be fine. But friends, if there is a problem, there must be some reason. So let us go a little back and see where did I go wrong. On examining the video carefully in slow motion, I realized that at this point my phaco tip inadvertently aspirated soft cataract with cortex and caused capsule defect, which went unnoticed, and later it became apparent only after extension of rent. So what to do now? Here our first goal is to prevent extension of PCR. Second goal is to remove remaining cataract and cortex. Third goal is to do nice vitrectomy and minimize vitreous loss. Fourth goal is to implant intraocular lens, preferably in the bag. But friends, there is a plan B, that is to put IOL in the sulcus with optic capture if there is no adequate PC support left. So when I realized that there is a rent, I actually took half a minute to calm down and I did my planning, and after that I restarted. So you can see I am injecting viscoat, that is dispersive viscoelastic having sodium hyaluronate and chondroitin sulfate under the capsulotomy, the way we do hydrodissection, to put a layer of viscoat behind the corticoepinuclear plate, and you can see that infratemporal cortex and plate has been levitated above and towards the center. Now you can see I am making a new phaco tunnel 2.2 mm supranasally because you can see that PC rent has happened infranasally, so a new port placed supranasally will shift vacuum and aspiration away from the PC rent. And you can see I have been able to remove the lower half of remaining nuclear and epinuclear plate successfully. I am injecting more viscoelastic under the anterior capsule, over the posterior capsule and over the area of PC rent. And now I am removing cortical plate with the phaco tip itself. Friends, it looks risky, but because I have injected viscoat over the posterior capsule and over the capsular rent, it actually gives a very good support and it don't lead to extension of posterior capsule here, as well as it makes our job easy. Injecting some more viscoat over the posterior capsule to push PC backward. So here is my first tip, that do use dispersive viscoelastic over the posterior capsule as well as over the rent, because it acts as a pseudo-vitreous and it prevents suction of posterior capsule as well as vitreous. As you can see, I have rotated upper part of the cataract towards the center and then I am gently aspirating the remaining cataract. Yes, I am keeping patience and going slowly. This complete surgery took approximately 32 minutes, but I have edited and clipped the irrelevant portions to make it short. Because cataract is soft, so what I am doing is I am aspirating the cortex intermittently while I am injecting viscoat repeatedly to keep the capsule backward. And now I am gaining confidence that probably I will not need to do anterior vitrectomy, because till now PC rent has not extended and I have been able to remove major part of the cataract. So this last remaining part of the cataract, if I am able to remove and there is no extension of PC rent, then I will be able to prevent even the need of anterior vitrectomy. As you can see here, that PC rent has not extended, and now you can see I am injecting methyl cellulose in the bag and there is already dispersive viscoelastic present in the bag, so it becomes kind of a soft shell technique where there is a periphery of viscoat along with methyl cellulose in the center. This makes it easy to insert the IOL in the bag, and also it will help in rotation of IOL, and now I am implanting lens in the bag. Here I am pushing the lens inside. You can see lower haptic has gone into the bag, and upper haptic I will be pushing behind the anterior capsule by tucking it. I am being very cautious that I am not rotating my intraocular lens at this point till haptic is completely unfolded and has reached the equator of the bag. And you can see now that lens is very well inside the bag, and now because this is toric lens, so I'll be rotating this lens, and you can see with gentle maneuvers I've been able to place the lens appropriately at the right axis. And now you can see I am removing the remaining cortex. This is the cortex in the area of PC tear. And you can see lens is very well centered in the bag behind the anterior capsule. Friends, though it is very clear that there is no need to do anterior vitrectomy at this stage because lens is very well centered, and also there is no apparent vitreous in the AC, but because vitrectomy probe was made ready by my assistant, so I thought let me do removal of viscoelastic by using vitrectomy, and by chance if there is any strand of vitreous, it will also be removed. Once viscoelastic has been removed adequately, I am confirming the alignment of Panoptix Toric IOL with the marks on the cornea, and yes, you can see the IOL is perfectly aligned. The toric marks on the IOL are matching with marks on the cornea. And friends, because I don't want my chamber to collapse, I am trying to do hydrodissection keeping my irrigation on, and I will remove the irrigation port once I am sure that chamber is not going to collapse. And yes, you can see I have been successful in doing so. Now I have injected pilocarpine into the anterior chamber to constrict the pupil. This helps multiple ways. First of all, it will confirm that there is no vitreous in the AC, and it will also confirm the alignment of IOL with the pupillary axis. And you can see all the multifocal rings on the IOL are very well centered. Friends, if there is a PC rent, I generally put air bubble at the end of surgery, but in this case I am avoiding it because I believe it will cause differential pressure on the iris, and which may cause tilting, shifting or rotation of the IOL. So in toric trifocal IOL, I am not putting air in the AC. These are the highlights of this video. And at last, thank you friends for watching this video, and I will welcome any comments or suggestion from my colleagues.